We're very excited to have Dr. Diane Dietzen from Baystate. So nice to meet you. And she's going to be speaking to us about palliative care, a hugely important topic that I don't think we talk about enough in medicine. And it's really important to people who might be in a place in their cancer journey where, it's not a quick, okay, we're going to take it out and you're going to be done with it. So here's Dr. Dietzen.
Hi. Can everybody hear me okay? All right. So I give you all credit. You're still here. You've learned a whole lot today, and I'm sure that you're starting to get to the point where information overload is setting in. So I appreciate your sticking around. We're going to talk a little bit about palliative care and what it is and what it isn't. And the reason the lighthouse is there, because that's how I view palliative care, as a set of people trying to help you get through whatever the fog or the storm might be that happens to be going on. So in order to talk about this, we're going to have to talk about some terms first. And you guys have been talking about survivorship care all day. And I think there is a huge set of questions that we can talk about at the end about how palliative care overlaps with survivor care and where the similarities and differences are. But I really want to talk about the definition of palliative care and the kind of companion term supportive care. And then we need to define the term hospice, because we need to understand that palliative care and hospice care are not the same thing. So quick question. How many of you have heard the term palliative care before? Good. How many of you have read or seen something in the news about palliative care and that's how you learned about it? Okay. How many of you have met someone who is a palliative care provider? Okay, good. All right. So we're headed in a good direction here. So I really want you to focus on this definition. There is no one magic definition of palliative care, but I think this encompasses the things that I really want you to take away from this talk in one slide. Okay. Patient and family centered. So about the patient, but also about the people helping to take care of that person, that optimizes quality of life. Okay? We're not talking about end of life. We're not talking about optimizing that aspect. We're talking about optimizing the quality of life by anticipating, preventing, and treating suffering of any kind. Palliative care can happen throughout the continuum of illness. It can be about physical symptoms, emotional, social, and spiritual symptoms. And the goal is to try to facilitate patient autonomy, access to information, and choice. Okay, so anybody want to just reflect for me, is any of that sound different than what you understood the definition of palliative care to be? Nobody wants to volunteer. Okay, that's good. So again, pretty comprehensive. It sounds like it really should address everything, maybe is even a little bit too big. In terms of all the things that are up there that we might be trying to help address. In the end, I think we all hope that all medical care comes back to trying to do these things, right? That it shouldn't necessarily have a separate label. And we'll talk a little bit about that more down the road a little. So palliative care is really good comprehensive treatment. It has a lot of evidence behind it in terms of people with cancer and other illnesses getting palliative care and having better outcomes. Really tries to focus on the best possible management of pain and symptoms. Can happen at the same time as curative treatment. And again, in this day and age, often does. So is not something that is entirely separate from the treatment that you're getting for the cancer or another underlying illness. It is not about giving up. It is not about saying that curative therapy is not being discussed, and it is not the same as hospice or end-of-life care. And those are really important messages that I want you to remember, but I also, as we've pointed out, you guys are ambassadors, and you're going to be talking to a lot of people who are still confused, about this terminology, and who are afraid or fearful about talking about palliative care. And I need you to help them understand that it is the things that I just pointed out. It can happen with any diagnosis. Certainly there's a lot of palliative care that's done for patients with cancer and in cancer centers, but there's also now a lot of palliative care that gets done in patients who have underlying heart disease and require these kinds of comprehensive services, or underlying lung disease or a neurologic disorder. So there are lots and lots of different applications for the same idea that we're trying as hard as we can to be comprehensive in providing quality of life. Can happen at any age, can happen for pediatric patients, geriatric patients, and patients in between. Can happen any time in the course of an illness. And we're going to talk about this a little bit when we talk about examples, but can happen and does happen now in many cancer centers at the time of diagnosis of certain kinds of cancers, because just to get through the complexity of the treatment, it's helpful to have palliative care there addressing concerns, managing symptoms. It may also stay then throughout someone's treatment in order to help with the symptoms and to help in making decisions about other complex parts of the illness that may happen down the road. It complements the therapies that others may be offering for the disease process itself. At some point in an illness, it may become the total focus of someone's care, but often it continues to be a companion to other treatments. This is my palliative care team. And the other really important part about palliative care that I want to make sure you understand is that it's best done by an interdisciplinary team. And that because in order to address all those domains that I was talking to you about, the spiritual, the physical, the emotional, you need physicians, nurse practitioners, physician assistants, nurses, social workers, pharmacy, chaplaincy, sometimes complementary and integrative care providers. All of those can be members of an interdisciplinary team, and they really are a critical part of having this work go well. So I've already said this, but palliative care and hospice care are different, but people get confused. It's part of what makes the terminology anxiety provoking. And we all need to be able to talk about both. So we've explained why palliative care is different. I just want to remind everybody what hospice is. And again, some of the same words. It's support and care for persons who are in the last phase of an incurable illness. So again, that they can have the best quality of life that they can. The hospice part is about the end stage of a complex or terminal illness. And it has to do with really thinking hard and making choices about services that you might want to have in order to provide the best quality of life at the end of life. We have to try really hard not to be afraid of either of those words and to be able to talk about both of them and ask questions about both of them, understanding that they're different. Okay, so fit palliative care in with cancer survivor needs, remembering that we're talking about cancer survivor as something that starts at the time that you are diagnosed with the malignancy. Certainly, there are plenty of symptom management needs that we're going to try to address. There's going to be lots of needs for caregiver support that palliative care is going to try to help with. We're going to try to provide resources for care. We're going to try to provide a lot of support for helping to make decisions and thinking about goals for your care. So less talking about, or at least not initially talking about so much the specifics of the radiation therapy and what it might look like, but what is it going to mean for you and what are the functional outcomes going to be? And is that something that sounds like what you would be interested in, or is it not? And then a lot of thinking about follow-up and coordination of care in the community. So there's a lot of overlap here, and you guys have seen a lot of pictures that look like this during the course of the day today. And again, I think this is part of the whole idea that the place where we are now in terms of survivor care and palliative care and cancer care is this kind of murky place. And I think eventually we'll get to the point where these services don't get called different things and they all get delivered properly to the people who need them. But right now, some of what happens by the oncologist in the cancer center. Some of what happens by the primary care clinician, and some of it happens by palliative care teams. And sometimes there's perfect overlap in all of those things with good communication, and sometimes there isn't. And so we still have a lot of work to do there. So it is confusing. All of these people want to be patient-centered. They all want to try to address the things that we've been talking about today. So they overlap in that regard. The disciplines involved may be a little bit different. Okay, the standard disciplines available in the cancer center may be a little bit different. than the ones that are available on the palliative care team. In other words, the kinds of providers. Everyone wants to try to be as comprehensive as possible. And everybody at this point recognizes that there has to be something that includes the caregivers in this discussion, that you cannot have these conversations with patients separately without including the people who are actively involved in figuring out how to make that happen. And none of these necessarily are related to saying that the plan is curative or not curative. So none of that is different. So going back to the idea of kind of the lighthouse and how palliative care might help someone going through a diagnosis like this, these are the things that we're going to focus on, which we've already talked about. I'm going to talk about some examples. So often there are symptoms, and again, I think we've heard a lot about this today. Those symptoms might be related to the cancer itself, or they might be related to treatment. So it might be, pain from the initial presentation of the cancer, or it might be neuropathic pain from the chemotherapy. All of those are possible. There are a lot of symptoms that are not pain that we sometimes forget to think about and ask about that are really important. There are a lot of symptoms that patients have because they have lots of other illnesses as well. They have underlying heart disease. They have chronic pain from arthritis. They have other things that are going to need to be taken care of in a way that helps them to get through their cancer treatment. And we want to make sure we're thinking about how all of that impacts on their ability to function in the way that they need to be able to function. So for example, this is a place that palliative care might be of use. You have a young woman with metastatic breast cancer who is due to be started on both chemotherapy and hormonal therapy. She has bilateral arm pain and fatigue, and she's expected to have nausea and more fatigue related to her initial treatment. What a palliative care team in a cancer center would do in that circumstance is really have a comprehensive review of all of her symptoms. And there are lots of tools out there that give you the opportunity to not just talk about pain or shortness of breath, but to talk about fatigue and anxiety and other sources of distress and compare them over time so that we can tell how we're doing with our therapies. The common ones, pain, fatigue, depression, anxiety, insomnia, we're going to especially focus on. And we're going to try to come up with a management plan for each so that she can continue to come back to the cancer center, get her therapy, and check in with the palliative care doctor. Yes. Up? You're not hearing me well enough? Okay. All right. So that's the symptom management part. Goal setting, decision support. We really want to make sure that everybody who's going through an illness like this has started to have goal setting conversations, has done some thought about advanced care planning. Basically everyone should do that, right? But especially someone who's embarking on this kind of treatment should do that. So how many of you all have a healthcare proxy? All right, not everybody. Okay, so every adult should have one. So we'll start there. And that's only the beginning part of that discussion, identifying someone who's going to be there and advocate and speak for you if you're not able to speak for yourself. But then to begin to have a conversation about what's important to you, what kind of outcomes are important to you, what kinds of things are you willing to have as treatment, what kinds of things are you not willing to have as treatment. Not because they're all happening right now, but because all of us need to get into the habit of being able to have these conversations with the people who are going to be at that bedside when the day comes that we might not be well. So as an example, palliative care might help in a situation like this. If you have a 67-year-old gentleman who's had surgery for lung cancer, but also has severe emphysema, which is a pretty common scenario because there was a previous smoking history. And he's had the cancer surgery, and people are actually feeling that there was a good opportunity that was a curative surgery. Nonetheless, he should have a healthcare proxy. He should have a discussion about other cancers that might arise. He should have a discussion about problems that can develop as someone's emphysema gets worse. Again, not because these things are happening right this minute, but because that way they can have an opportunity with their loved ones to talk about decisions that might come down the road. So we're going to encourage that to happen. We're going to encourage that to be documented and shared with people so that everyone has a common understanding. Okay, care coordination. You all know very well that care coordination is really, really hard in these circumstances, and that is a place where palliative care tries to assist, again, by using the members of the interdisciplinary team to try to think about where is the care outside the hospital, who's coming into the home, who's talking to those people, is information getting transmitted from the cancer center to the primary care doctor, to the people who are coming into the home, things like that. And are there other resources in the community that can help someone who needs help with functional or financial or other information? So again, an example, you have a 50-year-old lady with ovarian cancer who is about to be offered surgery as a treatment for recurrence of the cancer. She unfortunately also has heart failure and has chronic pain from neuropathic damage from her previous chemotherapy. She lives by herself, and she's about to go in and have this surgery. So our goal would be to sit with the patient and her family member, think about what will happen before the surgery, what will happen during the time of the surgery, what will after the surgery look like, what kind of symptoms might we expect, how would we change her medicines maybe during the course of the surgery, and make sure everyone understood that piece. And then think about what community services is she going to need in order to get through this period of time of the surgery and hopefully go back to her previous level of function. All right, and then emotional and spiritual support, also a huge part of what we try very hard to provide to people. That might be in the form of counseling or just general support, spiritual assessment, and then again, offering of appropriate spiritual support if that's something that the patient and the family want. Always really, really using the patient and the caregiver and family as a guide to what's best for them. An example, 60-year-old gentleman diagnosed with prostate cancer. They've been presented with all of the complex options that we sometimes present to patients with prostate cancer. You could have radiation, you could start with surgery, you could start with hormonal therapy. They're thinking about those things. And because of that, the gentleman is having a lot of difficulty with sleep and anxiety, and he's feeling frustrated and is having kind of a why me reaction to having to go through all of this challenging work. This is a situation where, in addition to having a palliative care physician or nurse practitioner provider, we would make sure that the family and Mr. D had a social worker and a chaplain to help them work through some of these things and talk about them over time, so that they had an opportunity to get some of that information out and talk about it, so that that will help in hopefully the getting through these treatments. Obviously, can change over time what a palliative care provider is providing. Early in the course of an illness, or when somebody's moved through the treatment stage to survivorship without active treatment, there may still be ongoing symptoms. There may still be ongoing spiritual distress. There may still be a need for some future advanced care planning. If someone's in the middle of treatment or has locally advanced disease and has to make different decisions about complicated choices in treatment, that may be the biggest focus of the palliative care service and the care coordination piece. And then if someone arrives at a point where unfortunately they have advanced disease, thinking about goals, decision-making, symptoms are going to be important, but the symptoms and the way in which we approach those things may be somewhat different. So, questions about any of those examples? Okay, so why does palliative care exist? Unfortunately, because even though we would love to look at that definition and say that all of medical care works in that way, it doesn't. We should be all striving to make it work better, but we don't sometimes do such a good job of symptom management. We don't do such a good job of communicating about outcomes of treatments. We don't, at least as providers, and I'm speaking of myself as a healthcare provider, we know from looking at studies of other doctors, oncologists, other kinds of care providers that we sometimes don't do a good job of starting from what is the outcome that the patient wants and then going back to what are the treatments that will get the patient there. We start from what are all the treatments we could possibly do? We make it a lot more difficult to talk about. Palliative care exists because care is fragmented. It needs to be coordinated. And because healthcare costs have been escalating in part because we do such a bad job of asking people what it is they truly want. Not because we're trying to limit or ration care, but because almost no one wants to end up in the intensive care unit. And it's often for want of a conversation about what that is going to mean and what that's going to look like. And people want it when you describe it as the things that I'm describing, and you ask people, is that the kind of care you would like to have? They say yes. All right. As I said before in the beginning, it's very effective. So effective, in fact, that ASCO, the organization that you've heard about for clinical oncologists, says that palliative care should be integrated from the time of diagnosis in many different kinds of cancer, not necessarily all. And that if you look at it in terms of research studies, it's definitely been shown to improve pain control, improve management of other symptoms, improve the provision of care that matches what someone said their wishes were, and lessen caregiver distress. So there is great evidence that palliative care, in fact, does all of these things. And in one study of lung cancer patients, people lived longer when they got palliative care than they did when they got routine oncology care, even though they were getting all the same aggressive treatment. So where does palliative care currently exist? These are all the places it could possibly be. Unfortunately, what I'm going to tell you is that based on the community, where it is very different from community to community, okay? So here in the greater Springfield area, we have palliative care at Baystate Medical Center, which is where I work. We have some home health agencies that provide palliative care in the community. We have a palliative care clinician who's actually calls it the supportive care clinic in the D'Amour Cancer Center that's affiliated with Baystate. We don't have a lot of palliative care that's happening in nursing homes around here. But there are examples all over the country of much more comprehensive palliative care services that have outpatient clinics, that have nursing home presences, that have lots of other places that teams are able to visit and provide this kind of care. How do you get palliative care? Generally, you have to ask for it, unfortunately. We should be offering it routinely. There should be triggers. It should be happening. But often it takes asking that question. And there are still oncologists out there who will go back to the beginning of the talk that we're just having now and think that palliative care and hospice care are the same thing, and that they shouldn't talk about palliative care until the patient has gotten to the point where they think they need to be talking about hospice care. And what I want you to go back and say to them is, no, that's not true. I need a palliative care team now to help me get through this treatment or to help me decide what I would like to do next, not because I think that we're at a point of an end-stage illness. So you have to speak up and advocate for yourself, unfortunately. There's a lot, as I said, when I started to think about this and read about this, I think there's a lot that's happening in survivor care and palliative care that overlap. And I think that over time, I hope what we're able to do through advocacy from people like you is to think about how to streamline that and how to stop calling all of this different things and how to just give people the resources that they really need to get through what is going to be an increasingly complicated set of treatments likely for cancers over the next 10 or 15 years. So I think that is everything. There are, again, lots of organizations out there that think palliative care is a good thing. There's a lot of resources on the web that I can give you to look for more information about palliative care at some of these sites. But basically, that is my message. I'm happy to answer any questions that you have. Yes. Okay. So that's a really important question. Thank you. So that is a part of the reason that palliative care is spotty in how you can obtain it, unfortunately. So, for example, in the hospital, when the palliative care team is consulted in the hospital, basically every insurer that the hospital takes pays for that consultation in the same way that they would pay for the cardiologist to come and see you if you were in the hospital and you were having an abnormal heart rhythm. Okay. So that is reimbursed in a way that allows people to provide those services. In the home, it gets reimbursed by most insurances in the same way that the visiting nurse does. So it's provided by most people's insurance, but it doesn't necessarily provide that whole comprehensive team. And people who want the comprehensive team, organizations that want to provide that, have to go out and find other ways to fund that, or have to get philanthropic funding in order to fund that. But all of the services that are provided are pretty much driven by what someone's insurance will cover at this point. Does that answer your question? Okay. Other questions? Yep. Uh-huh. So the palliative care team will certainly do the best job they possibly can to try to coordinate that care and communicate with your oncologist, and communicate with your other care providers. And we at Baystate spend a lot of time calling people, talking to people's doctors in Boston, trying to make sure that we understand all of the other people who are having input into someone's care. That having been said, it certainly is logistically easier if, you know, I'm able to walk up the hall and talk to the oncologist, and vice versa. So there is that to some degree. There's also, I think, the challenge of someone who's got a lot of symptoms or a lot of functional impairment who is wanting to go to Boston for treatment, but in order to get the kinds of things done that they need to do on a daily basis, they might need someone closer to home who's trying to help them with those things. And so we have to make sure that we're doing the best we can to overcome that. Yep. No. I would say that my honest answer is you have to do a combination. You have to get your oncologist to tell you specific trials that they know and specific people that they might know. And then you also need to look for yourself. But I would say that that's a place where, whether a palliative care team is then involved or not, that the next step after you have that information is to really sit down with a provider and your family and say, okay, here's what this is going to look like. Here are the side effects they're describing. Here's how much travel it might involve for me to do this. And here's the likely outcome. Here's what will happen if I don't do this. And really critically explore all of that before you make a decision. And that, to me, is the important palliative care piece there, is to make sure that you go into whatever that is informed and really trying to balance what you think the best outcome is for that person. Other questions? Yep. Mm-hmm. Yep, you can see a palliative care provider if there is one in the cancer center setting, and it will be, again, paid for like another outpatient office visit is paid. So for example, at the D'Amour Cancer Center, you can see the supportive care clinician as a separate visit, will be billed to your insurance, and you would pay whatever you would normally pay for a subspecialty visit under your insurance. Thank you for clarifying that. So I know it's the end of the day, so I will be here. I will be happy to answer other questions, but I don't want everyone to feel as if they need to stay, if they need to leave. So thank you very much.
Thank you, Dr. Dietzen, and to everyone. Please don't forget to fill out your sheets and drop them in the front. That would be most helpful so that we know how to prepare better for next time. Thank you all so much for spending your day with us, and we hope you took home some important messages. See you again. Bye-bye.